So we talked about this briefly, kind of the new models. On the left side, here's kind of the traditional model of like being fully insured. Your payer is bearing all the risk for the claims, they're paying it out, and your employer is paying a fairly large premium annually to the payer to kind of administer and pay out all the claims. In the ASO self-insured model, the risk is now going towards the employer. So your employer is actually directly paying for your medical costs. The plan in this case is really just administering and sort of facilitating that process. They're doing all the negotiations, but in the end, the actual payment is happening from your employer. And once again, I think the larger employers are kind of moving towards this model because it's a little bit cheaper than being fully insured. That's basically it. I think the next slide is where questions will start to get answered, hopefully.
And it gets more complicated.
I think we've been touching upon little bits and pieces of this the whole time, so hopefully this will kind of start bringing everything together. So when you look at the full kind of value chain or the full process at an insurance provider, at a payer, usually it's broken down, or when I say usually, it's by a very specific consulting company's framework, which I won't talk about, but it's through the front, middle, and back office. The front office is really the sales and marketing, it's the product development, the actuarial piece, all of that kind of happens there. That's kind of the front office. How do we create design products? How do we market these products? How do we sell these products? How do we interact with brokers? All of that is kind of managed within the front office. When we look at the middle office, that's where we get to the provider world, and how do we negotiate provider contracts? How do we do the utilization management, which is how I think we talked about earlier, the referral process. All of those interactions are kind of housed within the middle office and kind of managed there. And then when we go to the back office, that's where all the claims processing happens. That's where you get your member ID cards. That's where your enrollment information is kind of captured and referenced. And then finally, we kind of look at the overall corporate functions that any large business has. So that's kind of the high-level view of this. We'll dive into each one of these, unless you guys have specific questions right now.
Well, question in general for the group. Do you want to go, we have slides that delve into each, the front, middle, back office, and we can talk about those. Or the next section is going to go into the blues plans and how the General Blues Association operates. So some of the slides we can't share because it's proprietary. Some of them we can't just take that on. So we'll have to work with our other partners to determine which slides we can share.
Well, it'd be helpful to go through the meeting. We have to go through them quickly because there may be some information that's pertinent to Blue Cross in terms of how they're marketing that might be helpful.
Yep, Right. In front office. So as I mentioned earlier, really it's answering the question of how do we design, build, make all these products, and then how do we sell them to both our members and to our insurers or to our brokers. So kind of looking at the sales and marketing side, that's really managing the brokers that are out there. More often than not, they're working with insurance brokers, they're working with employers directly to kind of sell these products and also build products. More often than not, your employer is getting kind of a customized product, and so this is where that interaction, where that process kind of happens. This is also where the actuarial piece kind of comes into, where they're kind of determining what the risk level is going to be. More often than not, they kind of work with finance to determine the overall risk profile for the organization. But then this actuarial group will really kind of focus on, well, what's the risk profile for a specific customer segment or a specific employer? How do we build a insurance product around that kind of shares the cost evenly? So it kind of depends. Sometimes they're more closely associated with finance. Other times they're kind of more on this front office sales side. They kind of play both roles, and it's because they have to have such a close relationship with the sales and marketing team to determine, what exactly or how exactly we're going to price this product. So that's why we're sometimes lumped in here. I will continue to move on unless we have questions. the middle office piece kind of broken down to network management, which is really managing the provider side of the work. So credentialing providers, contracts, negotiating, all of that. That's kind of in that network management piece. The medical management piece is where you have the utilization management side, where this is where your provider is kind of calling your insurance plan to make sure that you're authorized for the procedure, trying to figure out all of that. That's happening with the medical management side, and it's actually, I think, in most places that I've seen, or most of the clients I've had, it's actually a lot of nurses that actually work in the medical management side, because they're the ones that have a full understanding of the kind of the clinical operations, and they can give better advice. I think a lot of the population health management also starts occurring in this realm here. So pharmacy is also kind of put in the middle office side, and and more often than not, I feel like the pharmacy piece is actually an outsourced vendor. It's a pharmacy benefit manager that contracts with the insurance plan and eventually kind of contracts with your employer. So it's kind of a few steps out. And then the informatics quality side, so all of the data around your claims, all of the data about the types of medical procedures that you're undergoing is usually housed in the middle office side. And all of the analytics and the population health management, this is where that starts to happen. So I think was it the event that we had with Wellmark, we had a few representatives from the informatics side. And that actually was a group that was really interested in innovation and trying to figure out better analytic tools.
So big data is big in healthcare right now. A lot of efforts and money is being spent on figuring out how to use all this data that's been collected by health plans. Health plans have more data than anybody else within the industry about you as because they not only see what the providers, what procedures are given to you, they also see, what prescriptions are made out to you and which ones you actually fill. Right? No other stakeholder within the industry has as much information about you as
Except they only have it for the period for which you are a member.
Yes.
So the information you're talking about is only claims data.
But claims data is pretty much everything you as an individual are doing within the healthcare space, right? So anytime you go to
Anything that's paid for. It
Yeah.
doesn't, if you went for a walk today.
And the other piece too is that they have tons of data. Most insurance plans don't actually know how to use that data.
Yeah.
They're still trying to learn how best to use that data. They use it on a very kind of baseline level to adjust their risk profiles and maybe include it in some of the provider contracting. But to really use it to encourage healthy behavior and to really use it for population health management is a new step for them.
So they're new at using their data for insights and prediction management. Are they using, for example, like credit card companies are, predictive analytics and machine learning techniques to sort of find things to use or be suspicious of in claims?
A bit. Yeah.
Oh, like multiplied claims, things like that?
Yeah,
Fraud
curious
prediction?
at what level that are they using predictive analytics and modeling machine learning for that stuff?
Yeah, I think you had an answer.
Yeah.
What, fraud of providers, you mean?
Sorry.
Do you mean fraud for the providers? So
Oh.
it's like if I saw you and you just had a headache and I upcoded it, it's called a heart attack. That's
Yeah,
fraud.
yeah,
You're
Claim by
using it
claim.
for that, yes.
Commodity.
And when did I start using those techniques?
Yeah,
It's a commodity. It's done.
yeah.
Yeah, I think on the claims analytics side, there are a number of tools out there that they've been using. I think it's more kind of holistically looking at the data to look at health versus
Yeah.
just fraud. It's kind of the new thing.
For the incentives are done.
Yeah.
Predictive analytics on big data is more useful on the provider side because if the patient comes in and it flags that watch out for this, then more useful on that. But I don't see how it's
Well, keep in mind that payers are now getting more involved in taking on, when they give risk to the providers give responsibility to them. Right? There's a symbiotic relationship there. So their payer is getting more involved in how the provider is actually delivering that care and understanding how to incentivize the right kind of care.
And also quantifying and qualifying an outcome. Like, how do you get empirical data to say within a range, if you got a great total need, past.
And I guess the other piece too is that your payer will also have on a member by member level, it's a full slate of providers that you see. Your specific provider will only have the data that he's kind of submitted or he's recorded. He won't have a full sense of all the other physicians that come up. The payer on the other side actually has a lot of that data and can work to coordinate that.
Always a good days to have a term like that in healthcare, but how valuable is data? So we come in, we focus on these problem statements. We say, well, as part of a engagement platform, we're going to pull all this data together. I wonder if really, does the payer really care? They go, okay, are they going to strive much value to a bunch of wellness data today? Maybe in the future, theoretically, knowing they take steps matters. I mean, you probably know better than you, but I don't know if they really care about that today. So if we say, with this engagement platform, all this data is produced, how much value do we strive?
I'm curious if it's like core and they're like it's like a ticket to the game. If you don't have that, then don't bother. Or if it's like actually strategic. Like they want it now and it's going to motivate the segment.
So,
or if they would get it and they wouldn't do anything with it, so it,
Or don't know what to do. Yeah.
It adds more
They're just like
problems maybe
collecting
to
data.
put in.
so on a payer by payer basis, it's going to vary. The more forward-thinking, more innovative plans are definitely moving in that direction, if not already investing heavily. So the example that Alec gave earlier, one of our previous clients in Iowa, they have brought in data scientists from NASA, MIT, Stanford, and they're investing millions of dollars on just one, aggregating all the data they have, because before it was held in silos within the organization, but then actually trying to figure out what to do. So I'd say BCBS Mass is definitely more on the innovative front, and they are looking at new ways not only to use the data they already have and have collected, but looking at new ways to aggregate new types of information.
The data in structured format, most of the data in structured format or not.
What they already have.
I would say it depends.
I would say
Yes, the answer is yes.
yeah.
And they're probably going to pay attention to where it hurts, right? The first thing you're going to look at where can we save money using this data? If that's, they're going to spend it. If they're not going to get a good return on
Yeah, I
investment.
mean, there's tons of articles out there already. Actually, we wrote one earlier this year about how there's all these wearable devices that are tracking all this information, but nothing is done with it. Right? You know how many steps you walk today. What was that?
So I just was at the Connect Health Symposium over the last couple of days, and both the head of Partners Healthcare as well as the CIO of Aetna actually emphasized the importance of small data. Because, like you said, there's a lot of data coming in, and most of it is not relevant. So it's about how can you understand when a change happens that falls outside the perimeters of what you expect to a wellness program to be. Whether it's somebody who's healthy or somebody who is living within a disease management program like diabetes, for example. When does it kick off decision support that allows you to get involved in that patient's care plan so that you can better prevent claims costs from increasing down the road? So it's more about, less about having this plethora of data that's pouring in. They have plenty of that. It's more about decision support, how to use that data to make insightful decisions.
Moving on to the back office. So back office is really where the claim processing occurs, but also customer service sits there. Customer service both on the member end, but also on the provider end, because more often than not, your provider will be calling in to your insurer and trying to figure out various things. And billing also occurs in this spot as well. So the bills that both the employer gets, but also that you might get as a result. So the COB, coordination benefits, but also the EOB that you end up getting, after you get
Explanation of
benefits, sorry, that you end up getting after a procedure, after you kind of go to the hospital. Like all that is generated in the back office and coordinated with all the other data there.
Since you talked about customer service, now can providers check whether the patient comes in putting in member ID to see if whatever procedure they want to do is covered or not immediately?
Yes. I work for a company that does that.
Oh, yeah. It's becoming more mainstream. It used to be slightly more difficult to do that at point of service.
Yeah.
But usually now, when you go to a doctor's office, your doctor knows what they're
Or they'll call in.
They aren't going to perform any procedure at the point of care unless they know that they'll receive reimbursement.
Yeah, exactly.
So the other interesting thing that's starting to happen more though is the cost transparency side of it, where a provider will now be able to at least get a broad moderate range or a range of estimate for what, as a patient, what your actual cost for this procedure is going to be. It's still kind of a few years down the line because the sort of real-time adjudication process, then the claims adjudication process isn't going to happen yet. Like, it's not as if your payer will immediately know what they're going to reimburse because it's that whole negotiation process. But you'll be able to get a better sense for what that cost might eventually be. Great. So, I mean, these are all the corporate functions, fairly standard corporate functions. We won't dive into this at all. One thing that we've seen, kind of now looking at this value chain as a whole, is that more and more that there are kind of specialized providers or specialized companies out there that are offering segments of the value chain. One area that I know is big is kind of that medical management space. So the population health management, there are a lot of companies that are just kind of providing that as a service so that these health plans actually don't need to build out that function within their own company. They're doing a lot of contracting, a lot more outsourcing around that. The other piece where I think outsourcing and kind of servicing has been fairly common for a while is that claims processing side. More and more just becoming a very sort of commodity activity. I think, one of the clients that I have, I mean, most of that is being outsourced to various parts of India. I mean, that's what's happening with a lot of the commodity functions on the back office.
It's the HIPAA problem with the outsourcing.
They find ways around it. A lot of that data is probably encrypted, or there's a lot of data masking kind of going around, so they're able to stay in compliance with HIPAA. But I know that outsourcing in that space is becoming very, very popular.
Question: where would you put that carve out where they're focused on population health as a
That's more the network and the medical management side. Actually, anything in the middle office, like all of that is really the population health management side. So looking at overall disease states and having the analytics and the data kind of background. And the other benefit for these kind of third-party population health management companies is that they have data across all providers, or all providers and all payers. And so it's kind of a different beast than when you have the data for your own membership. Trends. I think we've touched upon this a lot, actually. I think on the trends, kind of hit upon. We've talked about the focus on cost savings. This irrelevance one is an interesting one. We kind of talked about it when we showed that the data self-insured model, where if your payer is now, if your employer is paying out all of your claims, why does a payer exist, right? Like, why does the insurance plan exist? So if your employer can directly contract with providers, if they can directly contract with the pharmacy, what is the role of a health plan moving forward? And I think that's one thing that we're trying to figure out. And then the engagement piece is something we touched upon a lot.
Yeah, question there.
Yep.
Are you hardcore on how you stack rank those? Is it 1, 2, 3, or is it that's the top third? Just interested in your opinion.
I would probably reorder it as cost savings, engagement, and then the relevance piece. I think
You think cost savings in that 80% part is priority above patient engagement?
I don't think they're quite easy. I think engaging members is probably part of cost.
Right. It's the airline.
People think, I know you do have the term patient engagement, but I think there's also member engagement. How's the health plan thinking about that? Do they think engagement is kind of same, or there's one big bucket, or they think about how do we is engaging in wellness the same as engagement with their provider, or how are they thinking? Is there a ranking amongst what is engagement? Yeah. How are they thinking about it?
Well, I think this whole engaging member, it's a new concept for them. That's the thing, right? More often than not, the engagement that they've had with their members has been on, hey, my bill screwed up, like what happened, right? I think more and more, it's now this wellness piece, right? Like how do we encourage our members to have, better lifestyles, to lower our overall MLR, overall medical costs. So I think that's kind of where engagement is being focused. think the other piece too is just educating members. I think that's a huge piece of engagement. And as we move towards kind of a marketplace where they are more competitive and they're trying to bank on their brand equity more, they want to create these tools that can actually explain healthcare better to their members so that it's actually seen as a value. Like working for or being a part of the Cross Blue Shield of Mass, that's a health plan that's going to tell me all about the cost. Or that's a health plan that is going to let me know exactly what providers I should be using. That sort of engagement, I think, is going to build that brand equity.
So to be said another way, so the health plans want their members to go to the price estimation tool, right, the cost transparency tool, and go to the cheapest place to get an MRI, right? So maybe it's like where they get healthcare is cheaper for you, cheaper for them. But then how do they rank? Would they see that's more important than getting that patient to where they're good? And so if they're both engaging them in a way outside of like traditional, my bill's messed up, or is there a ranking amongst
I'm not sure if there's really a ranking. I think if you ask different stakeholders within the organization, they'll say different things. Off the top of my head, though, I'd say that traditionally they've gone more towards the cost transparency and things of that nature, as opposed to the new age of going towards wellness is an old term, but the way that we are thinking of wellness in terms of apps and wearables and things of that nature is kind of a new paradigm. And so that's something that some people are moving more towards, but
You go down to show the value.
exactly.
How can you engage with members? Because patients trust their provider more than insurance companies. If insurance companies are trying to engage the patient, then they'll be very skeptical because they trust their doctor.
We're just trying to facilitate discussion at this point.
I guess the provider, probably a nurse more than a doctor, but certainly a doctor more than an insurance company trust. But that's not to say that people trust the provider. Like, that's a very broad statement that I don't think is supported when you pass the person on the street. Trust the doctor.
Trust me, I'm a doctor.
Maybe you're a doctor, maybe you're a better doctor.
You're in trouble.
Well, I think it depends on what you're trusting them to do.
I've done enough user experience research to know that lots of people don't trust their doctors. Like, it's a core problem when you're making a health app. Like, people don't want to talk to their doctor about X, Y, or Z because they don't necessarily trust them. It comes up a lot.
And I think it goes to your point too. It's like, what are you trusting them to do? Your health plan's not going to be giving you a diagnosis. Right? No one would trust them to do that. But would you trust your health plan to give you recommendations on healthy food, or how much you should be walking or running, or if there's an organization nearby, eating Whole Foods versus going to Costco. But things like that, I don't think it matters whether you're hearing it from a doctor or a health plan, as long as you know that they have your best interest in mind.
I'm very interested in the engagement trend, as are a lot of us. And my concern is the word engagement seems to mean so many things in different contexts that I don't know what it means here. Or actually, what I really want to know is how do they measure whether they're doing a good job of engagement? For example, if you're making an application for Facebook, engagement is almost defined as your ratio of monthly average users to daily average users. Not wisely, but that's how they define it. So just how do they measure whether they're doing engagement well? Compliance, I see, is one.
I mean, once again, it's kind of a new thing for them, right? They're trying to define those metrics, right? They're trying to figure that out. Exactly what does engagement mean for them? How are we going to define that? How are we going to measure that going forward? How are we going to measure success in that space? Because as we kind of talked about, engagement before was purely that customer service call. Like that's how they define engagement, right? Whether or not you had a good or bad customer service experience when you called your health plan. As your health plan is now more involved in your health and involved in giving you advice, kind of managing the whole spectrum of activity around health, I think the definition of engagement and the way you measure engagement is going to change. And I don't know if anyone's defined that yet.
Were you, I'm not being a smart aleck, I actually don't know, were you joking when you said they defined engagement as receiving customer support calls?
No, that's
actually works.
true. No, that's true. Yeah. I mean, right now, like that's how they engage members, right? That's really the only time you ever.
That's
interact
actually
with
use the
them.
word engagement for that. Okay, so it's sort of like communication and interaction.
Yeah, it's interaction.
So, there are also, I know most health plans do some sort of survey with their members, right? So I think that the KPIs with how engaged members are will fall into those surveys, and I'm sure we'll be asking questions like, the additional services that are provided this year versus last year, what do you think of them, and things of that nature. But I don't think any specific KPIs have been developed, because that's why they're reaching out to entrepreneurs and startups like yourselves to figure out ways to engage. Once you have the way, then you can figure out the KPIs.
And so the pain that they're trying to cure with engagement is what? The fact that we hate them? I mean, not context, but,
I think that's one of the factors for sure. Their brand equity, as was discussed earlier. But it's also just how do you get people to live healthier lives and to have them understand that BCBS Mass actually has that in mind when they are trying to interact with their members. They're not just
by then I meant health plans widely, of course, BCS.
right. Health plans in general.
Isn't engagement, I mean, I would argue that because the way insurance companies are paying providers, that they now have to engage with patients differently than they have in the past. You got to pay for performance or pay for length of stay for a procedure versus pay for an outcome. It's a very different thing. So you want to, I think you want to engage your patient differently as a payer to make sure that they're happy with the outcome, that you're with them, and they're going to be more responsible than they have been in the past.
Definitely. I mean, yeah. I mean, that's going to be a big push for the engagement side. Is understanding the outcomes around pay for value, and truly defining that, collecting data on that to get a full sense for what the result and the outcome.
And get buy-in from the consumer.
Yeah, I guess I was going to just ask, like, do you know how they are thinking about measuring outcomes, like in ACOs and stuff like that, and how, what kinds of things are they talking about in terms of doing that, and shifting the whole paradigm of paying from the CPT code to obviously something else.
With another code.
What is
Well, I know that a lot of ACOs have like quality standards, and there's like kind of quality metrics that aren't as focused on the output of the activity. I don't know specifically kind of what those metrics are off the top of my head. I mean, once again, I think we'll start posting all of these questions that we can't answer right now on the LinkedIn group. So hopefully, we can address some of the questions that are outstanding right now.
And just one more thing on the LinkedIn group, not to plug, but the objective there is to really have conversations like these, right? So if you guys have questions, post them there. We'll do our best to answer them. Some of our mentors are actually going to be on there as well that have decades more experience than either of us. So the whole point of that is to really have conversations like these, so you don't just have us two answering questions, but the whole group.
I think the best way to engage patient is for payers to reimburse for patient education is they do not do right now. So that's why payers don't spend time educating patients. That's their problem with it.
Before.
Well, I was just going to say, it also depends, I would think, on the person and where they are on the continuum. I mean, you might want millennials because you want them engaged so that they'll be Blue Cross members at that time when they are healthiest. But, there may be a different level of engagement at a different time period in someone's life. If you have people who are have chronic disease, you may want them to come to see their primary care provider a lot because you don't want them to end up in the specialty care. So I would think that they would want to really be very segment-driven in terms of their engagement.
And I think you see that from the problem statements. I'm actually going to go into that in a minute. But there are different ways, like you said, to engage different segments within their member groups. Right? So with people in the boomer population that are just moving into Medicare, how do you inform them about the differences from the traditional plans to Medicare, how that all works? I mean, it's really confusing. I think everyone that goes through that, it's a whole new way of experiencing their healthcare. And so compared to millennials, where it's just like, okay, keep them as healthy and active as possible, and hopefully they'll be lifelong members.
ask your question.